What's up, Ninja Nerds? In this video today, we are going to be talking about anti-muscarinic agents. These are some really cool agents, and we'll get to talking about these in just a little bit. But before we get started, what I want you guys to do is, if you guys like this video, you benefit from it, please hit that like button, comment down in the comment section, and please subscribe. Also, if you want some great notes and illustrations to follow along with me during this lecture, which I really think will help you, go down the description box below. We'll have a link to our website where you guys can check all that stuff out. All right, Ninja Nerds, let's get right into it. So first things first, in order to understand these kind of anticholinergic drugs, and really we're putting this anticholinergic category into what's called the anti-muscarinic types of agents, we have to understand the basic physiology of the parasympathetic nervous system, right? Because these drugs, if you want to think about it, if they're antagonizing that type of muscarinic receptors, then they're kind of trying to work like a parasympatholytic, if you will, right? They're trying to oppose the parasympathetic nervous system. So let's kind of briefly go through this physiology. So when we talk about this, there is what's called acetylcholine releasing neurons and muscarinic receptors and nicotinic receptors present within the central nervous system. But what do they do? What is their function? Because what we're going to talk about is we're going to try to inhibit that. That's the basic concept of all these drugs. So the basic concept, if we were to zoom in here and look at some of these acetylcholine releasing neurons, or areas of the brain that are involved in acetylcholine releasing and muscarinic receptors, we get into the area first of the basal ganglia. So we have our basal ganglia, and you guys know a little bit about the basal ganglia and how it's involved in a lot of our movement processes, right? So the basic concept here is it's involved in regulating movement. And this movement, if you will, is really controlled or mediated by a balance between dopamine and acetylcholine. So if I were to draw like this kind of like little seesaw, let's say here, this seesaw is kind of really kind of keeping a balance of movement, and really is regulated by two particular agents on each side. One is your dopamine. The other one is the acetylcholine. Now, what we need to understand is in certain diseases, we have alterations in this particular pathway, which alters the patient's movement. So it is involved in the modulation of movement. The other thing that the acetylcholine releasing neurons or muscarinic receptors are present, because we're giving drugs that are blocking acetylcholine at the muscarinic receptors, right? There is a lot of muscarinic receptors in this little special center in the brainstem near the medulla. And this structure here is called the emetic center, or the vomiting center. And all that means is it controls our vomiting response. And there's a lot of things that trigger vomiting, right? This could be due to vestibular dysfunction, so a lot of like disequilibrium. It could be due to stretching or distension or irritation of particular factors within the GIT, or it can be higher level functioning that's driving this. There's a lot of things that can trigger this emesis, but the actual receptors are located on that center in the brainstem. So that's the basic thing I want you to understand here. Now, next thing is we also have muscarinic receptors that are present on the actual eye. Now, on the eye, you have different types of tissues here. On the eye, you have the muscles here for the pupils, and then you also have muscles which are involved with what's called the ciliaris. And the basic function here of this particular pathway is it generally wants to cause what? What does the parasympathetic want to do? Does it normally want to cause pupil constriction or pupil dilation? Naturally, it wants to cause pupil constriction. So the natural type of mechanism here is it wants to cause the pupils to undergo constriction. And then the other thing here is it also wants the ciliaris to be able to contract. And when the ciliaris contracts, this actually helps to be able to play a role, and when it contracts, it pulls open the angle where the aqueous humor drains. So it increases the aqueous humor drainage. And also it can play a role in accommodation of the actual lens. So it also can accommodate the lens for different changes in vision. All right, so that's the basic concept there. So we know central nervous system, the way it's actually mediating it here in the CNS is it's mediating this via movement via the basal ganglia and vomiting via the emetic center in the medulla. It also works in the eye to cause pupil constriction and ciliaris contraction, causing aqueous humor drainage and accommodation. The other thing is it can also act, real quick, what is the actual parasympathetic fiber, the parasympathetic nerve here that works on the eyeball? This is going to be the third cranial nerve, where we have other nerves of the parasympathetic nervous system that innervate the glands. This could be, what are the glands here? The lacrimal glands. This could be the lacrimal glands, and it can also innervate the salivary glands. And so obviously it's not too hard to imagine what these will do if they're stimulated. When they're stimulated by acetylcholine acting on the muscarinic receptors in these areas, they're going to cause, not too hard to imagine here, lacrimation, so they'll increase the tear production, and they'll also increase salivation. And so this may cause a lot of oral secretions to be formed. Right? And the basic concept behind this is that the parasympathetic is involved in the resting and digesting phases, okay? The next thing, it also, and again, what's the actual cranial nerves that are involved with this process? This could actually be a couple. This could be the facial nerve, and it can also be the glossopharyngeal nerve. So this would be cranial nerve 7, and also we can see this with cranial nerve 9, which is the glossopharyngeal nerve. Now the next one is the big boy, the vagabond. This is the vagus nerve, the wandering nerve. This one is the parasympathetic nerve that supplies a bunch of different types of viscera that are involved in our parasympathetic nervous system. Works on the heart, releases acetylcholine on the muscarinic receptors of our heart, particularly our nodal system. You know, you have the SA node, and then the big one, the AV node, bundle of His, bundle branches, all that stuff, right? It's going to particularly work on these bundle systems and then the AV node, SA node to slow down the heart rate. And it also wants to slow down the cardiac output because you want to conserve the amount of energy that the heart is actually going to be pumping and utilizing during a resting and digesting phase. So the other thing here is it works particularly on the bronchioles, right? The smooth muscle of the bronchioles. And whenever it works on the smooth muscle of the bronchioles, what it's actually going to do is it's going to induce what's called bronchoconstriction. So it may be able to induce bronchoconstriction because usually whenever your bronchioles are constricted or a little bit more tight, you're not going to have to be able to involve too much with airway movement when you're resting and digesting. So we don't want to utilize a lot of energy here. So it actually will cause some degree of bronchoconstriction. All right, so I really want you to remember these things because this basic physiology, all we're going to do whenever we get into the anti-muscarinic agents is we're just going to flip it. We're going to have all of these things doing the opposite of what we're talking about here. Okay. The next thing that we want to talk about here is how it also works on the liver. Now this is not a huge one, but the liver, it actually can increase bile release, which is involved in digestion, and it can also cause the smooth muscle of the GIT here to increase motility, and it also can work on some of the glandular tissues involved in here to increase secretions that are involved in digestion. So it can increase secretions, it can increase motility. These are huge features that I want you guys to remember for the GIT. The other thing here is that it's really interesting, like the sympathetic nervous system, right, is involved in potentially the patient being able to sweat. So, but the interesting thing here is that there is muscarinic receptors. So the sympathetic nerves are the ones that are actually going and innervating the glands involved in sweating, but the neurotransmitter that's released is acetylcholine. And then there's even some muscarinic receptors here. So it's interesting because this may even be involved in kind of a sweating type of response. So it may cause sweating. So you can see how some of these things are really going to play in whenever we talk about this stuff a little bit later. It's really going to be cool. We're going to make it all make sense. So we got the cranial nerves here, we got the sympathetic nerves, which are really supplying the sweat glands involved in the skin, but there is some acetylcholine being released here and some muscarinic receptors here that are involved in the sweating process. So we can technically include this here. There's also the sacral nerves, so S2, 3, and 4, which are also involved. So these are parasympathetic fibers that are going to be supplying some of the lower aspects of our abdomen and pelvis. So it'll go to the actual bladder, and it'll cause bladder contractions. And if it causes the bladder to be able to contract, it really contracts that detrusor muscle, it can lead to urination. And then it also can act on the lower parts of the GIT. So usually the vagus will go all the way up until you get to about the transverse colon, about halfway through the transverse colon. And then the sacral nerves from S2, 3, and 4 will supply like kind of like halfway from the transverse colon all the way down the descending sigmoid colon, etc. But it also is going to be involved in increase in the GI motility. So you guys can see here how a lot of this stuff is coming to play. And what I really want to outline now is, if we come back up, is I want you to understand now, if we were to give a drug that's going to oppose this. So we're going to give a drug that's going to act at the muscarinic receptor, and we'll show you that mechanism in a little bit. It's going to bind onto the muscarinic receptor and block acetylcholine from being able to work on that receptor and initiate its effect. So it's going to oppose all these actions. So it'll play a role in altering movement. Potentially, if you have some type of disease processes here, that can be a problem. It can potentially cause some problems with vomiting, but here's where I really want to get into it. If you're going to oppose this, what would it do? It would cause pupil dilation. It's going to cause the ciliaris to not contract, which is going to increase the aqueous humor accumulation. It's going to cause decreased lacrimation, decreased salivation. It's going to increase your heart rate, increase your cardiac output. It's going to bronchodilate. It's also going to decrease bile secretions, which are involved in digestion. It's going to decrease GI motility, which can lead to constipation. It's going to cause less sweating, which can cause your body temperature to go up. And it's going to cause less bladder contractions, meaning that you're not going to urinate, you're going to retain. And again, less GI motility, you're not going to be able to defecate, maybe develop constipation. So you can see how a lot of these things are really, really important to understand, the basic phys. So now what I want to do is I want to go over a basic kind of concept about how these drugs work at the muscarinic receptors, briefly talk about muscarinic receptors, and then go through the drugs and how they work on this particular diagram here. All right, my friends, so now we're going to talk about the muscarinic antagonists, the actual types of drugs, but also just briefly kind of go over how they work at the receptor site, just so that you understand, right? So we were kind of looking at all the nerves that were going to that ganglion, right? So you had potentially going into your postganglionic neuron where they were synapsing. So you had that synapse point, and then you had the postganglionic neuron going all the way to the target organ. Well, now what we're going to do is we're just going to talk about, okay, we act on the target organ. We talked about all the target organs that could be affected. The eyes, we talked about the glands, we talked about the heart, the lungs, the GIT, the bladder, the skin, all of that. Well, really how this happens, though, is it's happening between acetylcholine and the muscarinic receptor. So you have these receptors, these muscarinic receptors, and really what they are, they're G protein coupled receptors, right? So there's different categories. And so in this one here, I want to talk about what's called the M2 receptor, and then another one called the M4 receptor. And the reason why I want to group these receptors collectively is that these receptors primarily are going to be inhibitory types of receptors. So they're trying to be able to perform inhibitory functions. What do I mean? The primary organ I think is the best example in this situation is the heart. So if you guys remember, all of them, they were trying to increase motility, salivation, etc. In this situation for the heart, it's decreasing, it's slowing down something. And the basic mechanism here is that when acetylcholine is being released from this postganglionic neuron, it needs to bind onto this muscarinic receptor. So here is your muscarinic receptor. And when it binds onto the muscarinic receptor, it activates kind of an intracellular pathway. And the basic concept here is it decreases cyclic AMP, and it also causes two things. One, it decreases cyclic AMP, and it also causes potassium ions to be effluxed out of the cells. And so you kind of get a double whammy here where you get less cyclic AMP and less protein kinases that are activated, that are involved in all the phosphorylation reactions, but also you get an increase in the potassium leaving these cells, which kind of makes the cell become hyperpolarized and less active. That's why in patients who this acts on the heart, what does it do? It slows it down. It decreases the heart rate and subsequently drops the cardiac output. You don't really see that in a lot of the other target organs. So oftentimes the M2, M4 receptors are primarily your G inhibitory type of G protein coupled receptor. So these are primarily coupled with what's called a G inhibitory protein. They decrease cyclic AMP, decrease protein kinases, and cause potassium ion efflux. In the other situation here, where you have this neuron, it's releasing acetylcholine. This acetylcholine is binding onto this muscarinic receptor, and what it does here is it increases the cyclic AMP. It increases the protein kinase, which phosphorylates a bunch of proteins that increase cellular activity of some way, shape, or form. And if you increase protein kinases, what you'll see as a result of this is an increase in particular types of contractions, secretions, etc. And so for these, it's usually all the other receptors. So this is your M1, M3, and M5 receptors. So generally these receptors are usually coupled in some way, shape, or form to like a G stimulatory or GQ protein. They're more of a stimulatory type of receptor, okay? So usually, for the most part, they may be coupled with what's called a G stimulatory or a GQ protein. Either way, they're trying to increase the activation of enzymes to cause contraction. So this would be, I think the best example that I can think of here would be the bladder. So if you think about the bladder, what does it do to the bladder? It causes an increase in the contractility of the detrusor muscle to cause urination. So that would be kind of a factor here. Or on the GIT, where it causes an increase in contractility, increase in secretions. The glands, increasing salivary secretions, increasing lacrimal secretions. You get the point here. So it's important to be able to remember that this primary mechanism of action here is to be able to increase, in this case, urination. So I hope that makes sense. What we're doing when we give these muscarinic antagonists is we're giving a drug here that I'm going to use in red that's going to work here to block this reaction. So this muscarinic antagonist is actually going to come here and block this reaction, therefore blunting the inhibitory effect and blunting the stimulatory effect in this kind of muscarinic categories. So really try to be able to understand this basic concept. If you're a little confused, go watch our video where we talk about all the cholinergic receptors in our physiology playlist there. All right, but let's get into some of these muscarinic antagonists that are doing these types of opposing functions. The first one here is atropine. So atropine's a really interesting drug. What it does is it blocks the muscarinic receptors present within the pupil and the muscarinic receptors in the ciliaris. And when it does that and it actually blocks those particular receptors here, what's it going to do? Well, what did it normally do? Normally, it causes pupil constriction. We're going to oppose that. Do you see why I told you to remember this? It's going to cause pupil dilation. Why is that important? If you're trying to perform an eye exam on a patient and you want to be able to look at the retina or for whatever reason, you may need to allow for pupil dilation. It also will decrease the drainage into that canal Schlemm because remember, the ciliaris doesn't contract. So one of the big things to watch out for here is that it can cause a change in your vision, right? So it can affect the ciliaris. So the ciliaris actually becomes inhibited in this situation, and this may affect the accommodation, which may cause some blurry vision. But on top of that, it may affect the drainage of the aqueous humor, which can increase intraocular pressure. So you probably want to be careful of this with patients who have glaucoma, narrow angle glaucoma. This could worsen it. The other thing here is it acts on the glands, right? And what do these glands normally want to do when the acetylcholine acts on these muscarinic receptors? They want to secrete. So for the most part, most of these are going to be M3 receptors for the most part. So they're all going to cause a pupil dilation, and this you're going to generally inhibit them from causing constriction and contraction. So in this situation, you're going to pupil dilate and inhibit the ciliaris contraction. In this situation, you're going to decrease the secretions. So in this particular scenario, you'd see that the patient would have decreased lacrimation. This may dry out their eyes. You also will decrease the salivation. And this is an interesting type of thing here. Why would you want to do this? You would want to do this in situations where patients have like a lot of drooling. Maybe they drool a lot, or sometimes they use this pre-intubation or perioperatively to kind of clear up the patient's secretions when you put the tube in. So that there's not a lot of secretions that are going to affect them while they're intubated. So sometimes it can be done pre-op, or we can say versus pre-intubation basically, to kind of clear up some of those upper airway secretions to get them out of the way during the intubation. The next thing is if we come down here, it can act on the heart, right? Now, think about this. These were like your M3 receptors up here that you were antagonizing. What's this one gonna be? An M2 receptor. So in this situation, you're acting to, again, oppose the M2 receptor present on the AV node and SA node. So in this situation, they naturally want to decrease your heart rate, decrease your cardiac output. What do? Increase your heart rate, increase your cardiac output. So watch out for these patients to potentially have an increase in heart rate and increase in cardiac output. Why in the heck would you use this? You would do this if the patient has severe bradycardia. So if they have a severely low heart rate for some particular region, you can quickly, it's kind of one of the first line medications to give in symptomatic bradycardia. So I would potentially give this medication. So do you guys remember the particular drugs that we talked about just recently, the cholinergic agonists, particularly the anticholinesterases? So the cholinergic agonists. And these are particularly the anticholinesterases, and they were working potentially to cause some type of what we would potentially refer to as a cholinergic crisis. And we talked about how to differentiate this from someone who has like myasthenic crisis, right? We can give atropine to treat as an antidote in patients who have a cholinergic crisis due to increased cholinergic agonist type of use. So I would consider this as a antidote potentially in a cholinergic crisis. Okay, let's move on to the next drug. So we got atropine. Now we get this next one called scopolamine. Scopolamine is a really interesting drug. You use it a lot pre-operatively, post-operatively. Sometimes if you're going out and getting on a boat for the first time and you get a little bit of motion sickness. The basic concept here is that if you guys remember, I told you we'd come back to this a little bit later, is that this area is called the emetic center in the medulla, right? So it's called the emetic center. And the basic function here is that whenever there is this emetic center, it's involved in vomiting. Now remember, what I'm telling you is that generally, whenever there is a lot of this acetylcholine acting on these muscarinic receptors, whether it's an M1, M3, M5, it's trying to stimulate vomiting, okay? In that situation, I want to give a drug that blocks these muscarinic receptors on the emetic center, blunting the vomiting reflex. So what would scopolamine do? It would inhibit the vomiting type of process. When would we want to inhibit vomiting? The two situations here is we would want to do this in patients who have some type of motion sickness, because especially from that vestibular dysfunction, this can really overactivate that emetic center. So motion sickness tends to be a really, really good one. And I'm going to abbreviate this because it's commonly abbreviated, is post-operative nausea and vomiting from like the anesthesia and opioids and things of that nature, okay? So that's a really cool kind of thing there. All right. The next one here is called Benztropine and Trihexyphenidyl. So again, I told you I'd come back to the emetic center stuff, and I told you I'd come back to the CNS stuff with the basal ganglia. I wanted you to understand it here. So these drugs are really interesting. Remember I told you I used this kind of like balance beam, if you will, where we have, there's a degree of movement, right? So movement, if you will, is modulated by the balance between two particular neurotransmitters in the CNS. And this is dopamine, I'm just gonna put dopa, and then acetylcholine. In disease states where you have a massive reduction in dopamine, now acetylcholine may be overpowering, throwing off the maintenance and the kind of nice equilibrium of movement. And what kind of diseases would this now happen where now I have, since this is kind of going down, now acetylcholine unfortunately is going to have to go up? What kind of drugs could I do, or what kind of drugs actually potentially would decrease dopamine and cause this imbalance? And that would be a potential indication for Benztropine or Trihexyphenidyl. Or what kind of disease decreases dopamine release and causes this inadequate increase in acetylcholine pathways? Come on, I know you know it. Which dopamine is really important because it's released from this structure called the substantia nigra. What kind of disease destroys the substantia nigra and then drops your dopamine release within the basal ganglia? Parkinson's disease. So we can utilize this in Parkinson's disease, my friends. Parkinson's disease. And this may be helpful, particularly within the tremor component. So we might be able to reduce some of the tremors associated with this disease, okay? Particularly by affecting this pathway. What you're trying to do is, the acetylcholine levels are too high acting on those muscarinic receptors. What are you trying to do? Inhibit this excessive kind of inadequacy between dopamine and acetylcholine. You're trying to level this back out. But since dopamine dropped down, you don't want this acetylcholine working too much. So you want to inhibit some of the acetylcholine to try to reset that balance. So that could be one disease. What's another disease that actually doesn't destroy these, but maybe when dopamine is being released and it's acting on some of these receptors involved in various different pathways of the body, I give a drug. I give a drug that will basically work to oppose this. Sometimes we use this in patients, unfortunately, because they are a little bit delirious, they have some type of psychiatric disorder, but what it's going to do is it's going to try to reduce the dopamine levels. You guys know what these are? Antipsychotics. So antipsychotics may also produce this interesting type of effect. So antipsychotics, especially in like higher doses, what can they produce? extrapyramidal symptoms. They can alter the dopamine and acetylcholine balance. And if they cause extrapyramidal symptoms like akathisia and different types of similarities between the Parkinson's disease, Parkinsonian-like symptoms, what would we want to do? We want to give them this particular drug to alleviate the extrapyramidal symptoms caused by antipsychotics, which alter this equilibrium between these two neurotransmitters. All right, that covers this drug category. Now, let's move over here and talk about these other two drug categories. All right, so next one is this drug category of oxybutynin, Tolterodine, and sulfenicin. Now, these are interesting. So we got atropine, we've covered that one, scopolamine, Benztropine Trihexyphenidyl, and now we got these other ones called oxybutynin, Tolterodine, and sulfenicin. Probably commonly utilized one is oxybutynin. So it's really kind of straightforward to think about how this works, right? Naturally, whenever acetylcholine works on the muscarinic receptors in the bladder, what do they want to do? Cause bladder contraction. If they want to cause bladder contraction, that's going to induce urination. What if a patient already has too much urination? They're urinating undesirably, so they have urinary incontinence. So generally in this process here, what do we know is that this bladder, if it's under the effect of acetylcholine by the muscarinic type 3 receptors in this situation, what will it do? It'll increase the bladder contraction. And if you increase the bladder contraction, you'll increase urination. So what if the patient has a particular disease that you want to inhibit that? So now what I want to do is I want to give these drugs because what they're going to do is they're going to inhibit this process here. This would be in situations such as urinary incontinence or like urgency, right? So think about all those different cases. And I think one of the really big ones here is like overactive bladder. That tends to be a really, really big one to also think about here. So I think it's a pretty straightforward one, not too crazy, right? The next one is this next drug category. I was kind of potentially not going to mention it, but I think it's something to think about. Dicyclamine and hyoscyamine. We sometimes can use this because if you think about it, what is the acetylcholine that act on the muscarinic type 3 receptors present on the GIT? What are they going to do? They're going to try to cause increased GI motility and increased GI secretions. So if a patient has, let's say, increase in their GI motility, and that potentially causes an increase in movement, maybe some diarrhea. What if the patient already has a disease, or maybe they have a lot of diarrhea? Or if you increase their GI motility, this may cause, sometimes it really can, it can cause spasms within their GIT. What if I wanted to give these drugs to inhibit this process because they have too much spasms and too much diarrhea? Well, there's one particular condition called IBS. So, right, IBS is going to be irritable bowel syndrome. And there's two phenotypes, if you will. One is there's IBS-C, so basically irritable bowel syndrome where they have more predominantly constipation, or IBS-D, so irritable bowel syndrome where they have more predominant diarrhea. I would probably find some benefit to give this to a patient who has IBS-D. Why? Because what I'm going to be doing is reducing some of the spasm associated with this increased GI motility that they see in this disease and inhibit some of the diarrhea that they see within this potential disease. So remember this potentially in IBS-D predominant. All right, so let's come up here and talk about tertiary amines. But before we talk about tertiary amines, I want to quickly understand why did we discuss the difference here. So we finished talking about tertiary amines, we're going to move on to quaternary amines. Why did I categorize them like this? There's a particular reason, okay? If you remember, we talked about scopolamine and Benztropine and trihexyphenidyl. Do you see how these ones penetrate across the central nervous system? There's a reason why. Tertiary amines are lipophilic. And because they are very lipophilic, it's easier for these to cross the blood-brain barrier and then have effects upon the central nervous system. Drugs which are quaternary amines, these are hydrophilic and therefore have a difficulty being able to penetrate across the blood-brain barrier and affect the central nervous system. That's a really big point. That's kind of why I wanted to really kind of separate these two in that way. But now that we've covered the tertiary amines, and the reason why I wanted to do this is because scopolamine and Benztropine and trihexyphenidyl definitely have a lot of CNS penetration. We're going to talk about these two categories here within quaternary amines. The hydrophilic, less CNS penetration, more peripheral or organ involvement. Glycopyrrolate is actually a really interesting drug. Sometimes I'll actually use this drug a lot in patients who have a lot of drooling. So sometimes patients may have cerebral palsy, they have certain types of psychiatric disorders that may cause excessive amounts of drooling. And so what glycopyrrolate will do is we'll think about what does naturally the muscarinic 3 receptors present on these glands going to do? Increase secretions. And if you increase secretions present within the oral and upper airway, this can be somewhat problematic, right? Because it may cause increases in drooling, or it may cause increased respiratory secretions that can kind of clog up the endotracheal tube, make it difficult to be able to manage it, maybe cause some pneumonia, things of that nature. So glycopyrrolate is going to work to be able to inhibit this increase in secretions, kind of clearing up the drooling and removing some of these respiratory secretions. And the reason why this may be helpful is, again, same way we talked about atropine, maybe using this as a pre-op kind of situation, or a pre-intubation, and a way to clear up some of those respiratory secretions before the tube goes in, okay? So that's glycopyrrolate. The next one here is Ipratropium and Tiotropium bromide. These are actually really cool drugs. So again, we know that when we talk about what this does to the airway, there's actually muscarinic types receptors here present on the smooth muscle. And the muscarinic receptors here present on the smooth muscle of the bronchioles, what are they going to naturally do? They're going to try to be able to promote what type of effect here? Whenever acetylcholine binds, acetylcholine will provide a constriction. So it's going to act on these muscarinic 3 receptors and cause an increase in bronchoconstriction. And that can cause difficulty being able to ventilate air in and out, especially in what kind of diseases? And diseases such as COPD and diseases such as asthma, where they have problems with bronchoconstriction. What if I gave ipratropium and tiotropium to be able to inhibit this bronchoconstriction process? If I inhibit the bronchoconstriction, I'm going to allow for better air movement in and out of the lungs in situations such as COPD and asthma. The question that you may have, though, is what's the difference between ipratropium and tiotropium? Maybe you didn't have a question about that. I think it's relatively important to remember is that sometimes what's really kind of relevant here is that ipratropium is actually going to be more short-acting. So sometimes we call this what's called a short-acting muscarinic antagonist, right? Whereas tiotropium is going to be more long-acting. Thus, we call this a long-acting muscarinic antagonist. Relatively important to understand that, especially in the COPD and asthma videos that we've talked about. All right, my friends, that covers the cholinergic physiology, that covers the muscarinic antagonist. Now, the problem is, what if a patient takes maybe too much of these muscarinic antagonists? They get a little bit of a belladonna poisoning, we'll talk about that, or they take other medications that have anticholinergic properties and they develop some really nasty adverse effects like anticholinergic toxicity. What do we do then? All right, so anticholinergic toxicity. We'll talk about the causes, but the basic causes I'll just hit it with you right now, but then we'll space repetition a little bit later. It's basically you take too much of these drugs. You take too much of an anti-muscarinic agent, or tricyclic antidepressants, they have anticholinergic properties within them. They can also cause this as well if you take too much of them. The other ones could be antipsychotics. And then the last one could be first generation antihistamines. And the last one, I don't even know where you find, I'll show you guys a picture of it, but a belladonna plant, particularly the berries and the leaves potentially from that plant may have a lot of these anti-muscarinic types of anticholinergic properties that could cause anticholinergic toxicity. But the basic concept is just, again, in this situation, we're really dropping down the action. So everything that we talked about before with the cholinergic physiology, amp this down even more, so drop down. So let's see if you guys can remember this. For the CNS, it played a role particularly within movement, but it also plays a role within our degree of just basic cognition. In these patients, whenever they have this insane types of anti-muscarinic types of blocking, you get an intense change within their cognition. And it can even cause these patients to become extremely delirious. So it can cause delirium, it can cause an intense altered mental status, rarely, but possibly, maybe even seizures. Okay? The other thing is, again, it's going to cause massive pupillary dilation. So massive pupil dilation, and it also, again, is going to cause potentially a blurry type of vision. This could be because of the pupil dilation, but it also could be because the ciliaris is not going to be contracting, right? It's not going to play a role within that. Again, it's going to change the shape of the lens to accommodate it for more of a, particularly more of a potential change for near vision, so it causes a lot of blurry vision. The other situation here is it's going to affect the gland, so it's going to cause intense dry eyes and intense dry mouth. So watch out for dry eyes, dry mouth. It's also going to, again, oppose the parasympathetic effect on the heart, which is to decrease heart rate. So it'll actually cause massive increase in heart rate, so potential tachycardia, and it may increase the cardiac output enough that it causes hypertension, an increase in blood pressure. It also may cause pretty decent bronchodilation, which may sound really good, okay? And then also, here's where it gets a little bit more interesting. Remember I told you the sympathetic nervous system, particularly from like your T1 all the way down to L2, the sympathetic fibers supply the sweat glands, right? But the actual neurotransmitters that may be released at this point here is going to be maybe some acetylcholine, and there might be some muscarinic receptors present here. So if I give an anti-muscarinic agent, what naturally happens with this pathway is to induce sweating. If I inhibit this, I will cause very, very, very little sweating, so I'm not going to be able to cool my body down at all via evaporative cooling. And this may cause the body temperature to shoot up to the point where the patient can develop hyperthermia. Okay? So watch for very, very high temps in these patients. The other thing is that you're not going to be able to poo, so you're not going to be able to restock the lake with brown trout, right? And that's a problem. If you can't make the brown pickle, what are you going to do? You're going to have severe constipation. So these patients won't be able to allow for adequate contractions of their GIT, so they can develop severe constipation. That's a thing to potentially consider here. I would probably be careful giving this drug in situations such as, maybe I would actually potentially consider this. I would not give this medication, or I would avoid giving these medications in what types of scenarios? A small bowel obstruction, a large bowel obstruction, an ileus of some type where the bowels aren't already moving, because then you put this patient at risk of a perforation if they can't contract their GIT. Pressure can build up and they can perf. So potentially avoid that, right? The other thing here is that it can act on the bladder. Naturally, we want to cause bladder contractions. But if we can't cause bladder contractions because we're going to oppose this, what's it going to cause? Severe retention. And this retention can be a problem, right? So I would also be very careful and avoid maybe this medications in patients who already have issues with retention, and especially in situations where maybe they have like some type of BPH where they already have retention, maybe avoid that as well. And that brings me to this other conversation here. One of the really, really big ones here is, remember I told you, it causes the ciliaris naturally to contract, but if we inhibit that, it won't be able to contract, it won't be able to change the shape of the lens, it won't be able to open up that angle for aqueous humor to drain. And so because of that, you'd really want to avoid some of these drugs in what other situations? Such as diseases that have a high intraocular pressure, such as glaucoma, especially narrow angle glaucoma. So important contraindications that I wanted to just disperse in there with these anti-muscarinic agents, really trying to avoid them in situations where patients already have problem with their bowels, problems with their bladder, or problems with their eyes. But let's get back to the problem at hand here. Some of the key features is delirium, right? Altered mental status, seizures, blurry vision, pupillary dilation, so look for big honking pupils, dry eyes, dry mouth, tachycardia, hypertension, don't worry about this one, hyperthermia, constipation, and urinary retention. What I told you again as a spaced repetition is obviously causes here. If we were to go through them, it's going to be all of these anti-muscarinic agents that we just discussed. If you take too much of this, that could be one reason. The second reason that I would also consider these is drugs that have anticholinergic properties, tricyclic antidepressants, or what else? Antipsychotics are also going to be drugs that have these types of anticholinergic properties. The other ones are going to be first generation antihistamines. These also have anticholinergic properties. And the last one here is that belladonna poisoning. They may ask you this one on the exam, or they may present it in the clinical vignette. So belladonna, plant poisonings. And we'll show you guys a picture of what that looks like. But I think the big thing is you have this within the clinical vignette, that you had too much of these, or maybe you intermingled. That's another thing. Maybe you took one of these with this, or you mixed an antipsychotic with an antimuscarinic. Either way, you mixed drugs that had extra or additional anticholinergic activity, and you just had too much anticholinergic activity here that it causes these problematic issues. And then the last thing here is if we have a patient who has evidence of anticholinergic toxicity, right? Because they took one of these medications too much of them, or they intermingled a bunch of them, and they start developing these effects, what can we give them? The one particular drug that may be of benefit here is going to be physostigmine. This is one of those cholinergic agonists. So it's going to basically do everything opposite of what the anticholinergic types of toxicity presentation is. So this may be a potential drug to consider as an antidote in this situation, but oftentimes it's supportive care and allowing for the drug to be metabolized on its own. All right, my friends, let's do some questions here on muscarinic antagonists. So the first one here that we're going to start off with, here we go, some sarin gas. All right, so sarin is a nerve gas that is an organophosphate. It's a cholinesterase inhibitor, all right? And we talked about that one. It's one of those irreversible types, really nasty one. So which agent could be used as an antidote to a cholinesterase inhibitor? So in a patient who has a cholinesterase inhibitor, it's going to increase the acetylcholine in the synapses, which can lead to a cholinergic crisis. Which one of these drugs can be given in a situation of a cholinergic crisis? Because what it's going to do is it's going to help to potentially block the effect of the acetylcholine at the different types of muscarinic receptors. So in this situation, which would be the best drug of choice here, my friends? It would be atropine. We already know that atropine is going to be the particular treatment of choice in a cholinergic crisis. So it would be atropine. All right, the next situation here is a patient with asthma was prescribed a beta-2 agonist for the acute relief of bronchospasm, but did not respond to the treatment. Which drug is most likely next option for this particular patient? All right, so when we look at this, a patient with asthma was prescribed a beta-2 agonist. Now, beta-2 agonists are supposed to work on the bronchial smooth muscle and to do what? They're supposed to cause bronchodilation, but they didn't respond to it, okay? So if you gave them a beta agonist, they didn't improve. Oftentimes what you may do next is either bump up to the next particular thing. And so in this situation, one of the other drugs that is actually kind of interesting, that's a muscarinic antagonist that works against the M3 receptors that are present in the bronchial smooth muscle that also causes bronchodilation is ipratropium. So remember, ipratropium or tiotropium. It's just ipratropium is more for the short acting and tiotropium is more for the long acting, like once or twice daily kind of situations. So it would be ipratropium because, again, it's blocking those muscarinic receptors that also play a role within bronchodilation. All right, a 50-year-old male who is non-compliant with medications was recently diagnosed with COPD. His physician would like to prescribe an inhaled anticholinergic blocking the M3 receptors that is dosed once or twice daily. Which drug is most appropriate for this patient? So the ipratropium is more for acute exacerbations, PRN kind of situation. For chronic kind of daily management, long-term, once or twice daily, that's going to be the long-acting. So that would be your tiotropium or your LAMA. So in this situation, it should be tiotropium. All right, which is the most effective drug for motion sickness for a person planning to go on a cruise? Remember, the vestibular function is connected to the structure called the emetic center, which is present in the medulla that has lots of muscarinic receptors present on it. And if we give a particular drug that can block those muscarinic receptors on the emetic center and the medulla, it may inhibit the vomiting response due to vestibular dysfunction. And that drug is scopolamine. All right. Last question here, it looks like. So which drug is actually the most useful in treating sinus bradycardia? I think the best thing to think about is when a patient has bradycardia, usually if we want to think about this, it's usually due to the vagus nerve that could be releasing too much acetylcholine. And if it's releasing too much acetylcholine onto the AV node, it's inhibiting the AV node from conducting action potentials effectively, which slows down the heart rate. So if we give a drug that'll block the acetylcholine on the M2 receptors on the heart, it may be able to prevent the AV node inhibition and blocking and then allow for the heart rate to go up. And the best drug for that is going to be atropine. All right, my friends, that covers this case study on muscarinic antagonists. I hope it made sense. I hope that you guys enjoyed it. And as always, until next time.